Dr. Martinez, why don't you start?
Okay. All right. Hi, everybody. Hope you enjoyed your lunch. This is actually a sort of relevant question to that. The question is, do we feel that there is any benefit to taking curcumin 2K? Curcumin is it's actually a spice that is commonly used in Indian cooking, and there is some data indicating that curcumin can be neuroprotective and increase, just generally good, healthy things in your body. In terms of where I have, a grasp of where the research is on it, there's some definite indication that it can be good and beneficial. There doesn't seem to be any indication of side effects or adverse events, but we don't really know how much you need. We don't have a lot of information around, how often, or does breakfast need to have curcumin? So there's still more research that needs to be done. But again, since it doesn't seem to cause any harm, it certainly wouldn't hurt to take it.
All right. Dr. Callaghan, why don't you go ahead?
Okay. I don't take many supplements, but I actually do take that myself because it's a very, very potent antioxidant, curcumin. So very powerful anti-inflammatory herb, basically, and inflammation is a big part of Parkinson's and many other diseases. My question is, should all Parkinson's patients be changed to Rytary? I assume they mean if they're already on regular Sinemet, should all patients be changed to Rytary? I would say the answer to that is not necessarily, because it's recommended that you start Rytary 3 times a day, and it's recommended that you start regular Sinemet 3 times a day. So, especially patients with early disease, there'd be no immediate benefits probably. So a person with relatively early Parkinson's disease can take regular Sinemet 3 times a day and do just as well as someone who was started on Rytary. The million-dollar question is there a long-term advantage to being on Rytary versus immediate release Sinemet? And that study, we're all begging for that study to be done so we will know where to fit it in the treatment algorithm. The cost may be a big factor too. It just came out. It's a name brand medicine. It's unclear, if every insurance company is going to cover it and how much your out-of-pocket expense is going to be. It's a very good question because I think what I do is before I switch a patient to Rytary, I like to have them check and make sure they're going to be able to afford it long term, because the transition, when you transition somebody from regular Sinemet to Rytary, it can be a hard transition because we don't know the exact dose you're going to need, so we have to basically guess, and then based on how you do, we tweak it a little further. But that tweaking process means you have more symptoms, so it can be a little rough. And what I don't want to happen is for you to go through that whole transition period with free pills, because I have lots of free samples of this, because it just came out. I don't want to get somebody over this transition and they're doing great, and then they go to fill it and pay for it, and they find out they can't afford it. Then they got to go back to what they were on before. That would be devastating. So I like to make sure that people are going to be able to afford it. With the Medicare Part D plans, there's donut hole issues, so you could be doing good, and then the donut hole comes. That means you have to pay full price all of a sudden. So you have to know if you have donut hole issues with this medicine too, and if that's going to happen, can you afford the donut hole? So those are the kind of the short-term issues and the long-term issues with being on Rytary versus being on regular Sinemet.
All right.
Maybe I just can't hear myself.
Speak loud.
I need to speak loud, yes. I'm not the speech therapist. I'll just mention that. Is a particular exercise better than others? So with the big program, we talked about how we work on increased amplitude, which is that bigger movement. So just in your everyday life, if you're thinking big with your movements, that would help you more for people who are dealing with Parkinson's. But in my mind, walking is one of the best exercises you can do. It's low impact on your joints. And if you're thinking big, because it is something we do all the time, that's going to translate into other parts of your life. If you're walking big, you're thinking big, that's going to help. Do you want me to answer the next one?
let's get back to it so we'll
Okay.
have kind of a different flow.
Good.
So, sorry. One question is, how does Azilect compare with the newly released medication? So Azilect is a different type of drug. It does not provide, it's not dopamine, right? It affects the metabolism of dopamine down the line, so it's different. Azilect is one of the 3 different classes of medications that we have right now to help with Parkinson's disease, and it's a nice bullet to have in our pistol. I guess that's probably not the best thing to say sometimes, but it's a good drug to have available for you. So that's the way I feel about it. Anything else to add?
Yeah, Azilect can be taken by itself for Parkinson's, or it can be used with any of the other medicines. It's approved all 3 ways, and it's not the most powerful medicine we have, but it's good for early patients, I think, because it's once a day. And when taken by itself to treat Parkinson's, no side effects over placebo. But eventually people have to take other medicines with Azilect. But the good news is when you have to go on levodopa eventually, it acts as a levodopa booster because it inhibits the metabolism of levodopa, so it makes it last longer. So bottom line is it's once a day, it's well tolerated. It can be used by itself or it can be used with other drugs, and it boosts those other drugs. There's some evidence, and this is controversial, that Azilect may have some properties that make it disease modifying. So that would mean it could potentially slow down the disease, but that's controversial. They sought that indication from the FDA, and the FDA did not grant it. But there's some compelling data, and that's something to talk to your doctor about.
So can I comment on one thing about Azilect? It's an MAO-B inhibitor. We have a study under review which is basically showing, it's a retrospective study. So what we did not do, which you have to do to show true clinical efficacy, is do a prospective trial. But we took people at our baseline imaging who were on an MAO-B inhibitor and compared those to those patients not on an MAO-B inhibitor. And basically those that were on the MAO-B inhibitor had lower free waters and values in the substantia nigra, and they also had better bold contrast, which is a functional MRI measure, compared to those not on an MAO-B inhibitor. So their basically brain function and structure was a little bit healthier than those not on the drug. Just a comment.
Really good information. So why don't you read your question?
So I'll just read the question, which is kind of related to what I just said, but basically the question was anything reversing the free water space. And so my kind of feeling is right now there's nothing that's ever been shown to reverse that particular growing of the free water space. But the paper was just published a few months ago, so people haven't had time to sort of look at it closely. We ourselves are about to start a prospective study, or at least we're writing a grant to look at a prospective study. We're considering a number of different medications to try in that study. At the same time, my gut feeling is that a number of different medications which may be tried in different phases of development could be useful in evaluating on that particular measure. It's not going to be specific to something like alpha-synuclein. It may not be specific to another drug, but I do think that most any drug that is efficacious at slowing the progression of the disease would likely have to slow this free water measure, which actually may be why it might be such a good measure, because it may be broad and cover a number of different medications.
One question was, please explain downtime or wearing off. So this is a pretty basic concept that you'll hear that is easy to say, not well appreciated by people who experience it all the time. So as Dr. Callaghan was mentioning in the graphs of whenever you get good treatment with the medication, you'll feel better. In between doses, we ask if, hey, is the medication wearing off? We may ask you that in an office visit. By that we mean, are the good effects of the drug starting to decline to where you feel worse? In several different ways, but that's generally what we mean by wearing off. So feeling better from your baseline Parkinsonian state because of the drugs is where you get the good effect of the drugs, and as that fades away, that's wearing off the medication in general.
And that's something you probably won't have initially. That's something patients get down the road with Parkinson's. How far down the road really varies. It can be less than 1 or 2 years for sure, as some studies have shown, but it can be several years. Actually, I think overall you can sort of say there's about a 10% chance per year of those kind of things starting to occur. That's a soft number, but some people make that estimation.
And with therapy, initially we prefer to start when you're on your on time to kind of see what your baseline is, because that's 2 different baselines we'll get. We'll get your baseline and your on time, and then we'll get a baseline on your off time. So we want to be working with you on both times, when you're doing really well and when you're not doing so well.
All right, I'm going to answer one of these questions. So this is the first question. Am I aware of any connections to alpha-synuclein gene and regeneration in either humans or other animals? So I want to make sure I understand the question correctly. That would be, so we're talking about how in Parkinson's disease, too much of it or the wrong version of it seems to do bad things. Is there any indication that if you push it the other direction, that you could regenerate? I'm not aware of a specific study that has shown that in either human patients or in animal models. We do know from animal model work that if you knock the gene out, so you can manipulate the genome of the mouse or a rat and remove alpha-synuclein completely, and those animals are normal. They don't, there's no adverse event that happens. What we think is really tricky when it comes to alpha-synuclein is that obviously you need it in its natural form. It does something important. When it doesn't work well, bad things happen. But it's really difficult because even too much of the normal is bad. So it's a really, really tough nut to crack. But that's why we need to do more research on it.
I have a few questions here on the same subject, basically. The first one is protein and protein intake. So with dopamine, with levodopa, when you take the drug, and if you have protein in your stomach at the same time, the absorption of the dopamine into your brain is limited. It goes through the gut, and they use the same channel. So ideally, you want to have less protein in your stomach while you take the carbidopa-levodopa in whatever form. So practically, that's not always possible, but ideally, if you could limit the protein that's in your stomach, when you take the carbidopa-levodopa, it will help get a little bit more into your system and eventually into your brain. Now, that's not always possible, and it's not going to hurt you if you have protein on board and you take the medication. That particular dose just might not be as effective. That's kind of my take on it. Another question is specific diets that are out there that can, in the long term, help with Parkinsonian symptoms. I know Dr. Callaghan believes in this pretty strongly, so you might be able to talk about that a little bit better, like the wheat belly diets, et cetera. So.
Yeah, I have my personal opinion as to what might be a good diet, but unfortunately, we don't have good studies that prove, beyond a shadow of a doubt, what diet is helpful in the short term or long term. So in general, I definitely think it's important to be healthy with the diet, and I have my specific theories on that. And I would say I'd be happy to talk more in depth if you want to come see me. But I have some books I recommend, and I have my own kind of opinions. We talked a little bit about this last night. They're not widely accepted yet, and they have not been proven. That's part of the problem. But there's some decent data out there indicating that some types of diets may be very helpful. And I've have a few patients, trying these types of diets, and they're doing very well. So I'll be happy to talk to y'all about that individually.
Okay, if we could have a therapy question.
Okay. Is there any source material that explains specific weight routine or exercises for Parkinson's disease? I have about 14 pages of research here of different articles, if anybody's interested, that speak to voice training and physical training that help with specifically with Parkinson's disease. So come see me after and I'll give you that. So when it comes to weight training, specifically with the big program, we don't tend to use weights. We use full body movements, but there is the choice to progress to using weights if you're at a really high level doing very well and you want to challenge yourself using some light weights. And weight training in general, it's beneficial for anyone at any age because anybody can improve their strength, and then if you improve your strength, you improve your function.
Dr. Valancourt.
So I have a question here which says, what does clinically meaningful change occur in practical terms? So clinically meaningful change is meant to really define what is not clinically meaningful. And so if you have an outcome measure that is testing a drug or some therapy and it has a small effect on an outcome measure like a rating scale, then that would be a non-clinically significant change. So something that's significant statistically might not be clinically meaningful. But something that has an effect that is basically meaningful to patients, generally is agreed upon certain amount of change in an outcome measure, is what is deemed as clinically meaningful. And that's basically just the amount of change that would occur in a measurement. And it's meant to kind of separate what is meaningful to a patient from what is statistically significant.
Yeah, I would say on that UPDRS scale, if you improve, 3 or 4 points on paper, what is that? Does it really make a difference in your life? I think the best way of saying it. Can you do certain things better than you did before? If their answer is yes, then we think it's probably clinically significant. So, does it make your life better?
There are a few questions about the causes of Parkinson's disease that might pertain to individual person. I'm not going to address that specifically, but I will say that what we know about Parkinson's disease is that there are genetic links and there are environmental links, likely a combination of both. And, some people may be able to link one or the other to their particular case, but it does not apply to everyone. So, and I don't want to go into the specifics of somebody in particular state with these questions, but in general, that it's a mix of environment plus genetics that lead to Parkinson's disease and or a Parkinsonian state. And I say Parkinsonian state because there are you have idiopathic Parkinson's disease and different subtypes of Parkinsonian states that are out there, and their genetics and the progression of the disease are a little bit different. I don't know if you have anything else to add to that.
Well, I would just say that, I think that was actually a really good, way to make that understandable. And this is why I think that, from the Michael J. Fox Foundation perspective, as well as from, the way that doctors would treat their patients, with the different conditions, this is why it's important to really go after both types. So we have some clues from genetics, and maybe that's why you want to go after a certain thing. But you also want to find something that is consistent across all, if possible. So we call it different causes, similar mechanisms. So even if you have a genetic version of Parkinson's disease, sometimes you still have the similar pathways involved. And so if we can go after the pathway that crosses those different types, then that would be the best way to affect the most people.
I would add too, on a cellular level, and these guys know a lot about that, but when you look at when the researchers look at what's going on in the cells of Parkinson's patients, there's multiple different areas of the cell that are pathological, that are not working right. The mitochondria make energy for the cell; they're not working correctly. The lysosomal system, which clears the garbage, that's not working well. We learned about protein aggregation, that's going on. There's inflammation going on. So and there's several more that I didn't mention, and we find all these things going on at the same time, so it gets very complicated trying to figure out, well, what came first, which one should we go after and study more? We're studying all of them basically. We heard a lot about alpha-synuclein, but it's really they're studying all these cellular processes that are pathological, and the interaction is extremely complex, and it's like an onion. We keep peeling away layers, but the onion keeps getting bigger. And the more we learn, in some ways, the more we learn how much more there is to know. So it's just a seemingly infinite level of complication and complexity, and that makes it very difficult and expensive and time-consuming. But we're getting there, and certainly we know way more this year than we did last year, and you can say that about every year for the past 20, 30, 40 years with Parkinson's. I have a question here. I have two questions here. Somebody asked, tell us about Amantadine, which is a medicine that we use for Parkinson's, and why does it help reduce the wiggles? So that's what I call, the dyskinesias, sometimes referred to as the wiggles, the involuntary movements. Those are difficult to treat. Usually we like to try to treat those at first maybe by adjusting when and how you take your medicine so you don't get that peak, into the dyskinesias. But if that doesn't, sometimes you can't always do that, especially as the person gets more advanced in their disease. And in that case, I think a lot of movement specialists and other neurologists would think about using Amantadine. So Amantadine is kind of unique because we can add it, and it can reduce, not eliminate completely, but it reduces the amount of time per day that you have dyskinesias and the severity of the dyskinesias, so it helps dyskinesias without making some of the other symptoms worse. How does it do that? I don't think we know exactly, but because Amantadine is a drug that we call a dirty drug because it affects so many different receptors in the brain, and we're not sure exactly which ones are resulting in the improvement in dyskinesia necessarily. It's complex. In other words, it affects one system or more than one system, and those two together, have more of an effect than either one alone, maybe. So we don't completely understand it, but Amantadine is a drug that we're actually, that's one of our clinical trials at the NeuroMedical Center right now. We're looking at an extended release version of Amantadine and seeing exactly how much that helps dyskinesias. So that's actually one of the studies we're doing. It's still not going to answer why it helps, but we're going to, see if taking it a different way is better. And any study that looks at the magnitude of effect in more detail is, I think, a step forward.
You had another question?
Yeah.
While you're looking at that, I'll answer one.
Okay. Yeah, I haven't read it yet.
Sorry. How can I find out if I have Lewy body dementia? So we saw on a slide of a Lewy body earlier in the day, and a Lewy body, it's in the cell. It's a big aggregation of alpha-synuclein. And Lewy body dementia is not that. Lewy body dementia is a Parkinsonian state with dementia early on in the course of the disease. So it is somewhat of a clinical diagnosis. So it's something that you really need to just discuss with your treating neurologist.
All right. So both of these questions on this page are about the two new medicines that I talked about. The first question is, several of my friends around the country had to discontinue Rytary because it made them irritable. The other problem is that Rytary made the off time too hard. Have you seen this in your practice, and have you been able to overcome these difficulties? Remember I talked about switching from regular Sinemet to Rytary. There's the chart, and that tells us an idea of where to start, but it's pretty much a guess of what the dose is we think you're going to need on Rytary. And that transition period from regular Sinemet to Rytari can be very hairy. I just talked about this, how if we guess, incorrectly, then patients are probably going to have either more off time or more dyskinesias, both of which can be very, disabling and uncomfortable. So I'm sure that made them irritable, and this person who tried to switch, and they probably just had more off time. I would say that hopefully would not be very long of a time period at all, because as soon as your doctor found out, he would make an adjustment so that you would have less off time. That's the whole goal. So the transition period can be hairy. There's no doubt about it. And especially it's kind of brand new, and we're not sure, we don't have like years of experience with it yet to know, okay, in this scenario, it's been my experience that the patient needs this much. All we have is the chart right now in our gut, and that's not perfected yet. So as we get more experience with it, I think the transition period will be less hairy. But right now, hopefully it's not too bad. I've had a few patients on it, and some people had a pretty seamless transition. Others, it was a little hairy, and they call the office the next day. Oh my God, I'm having this problem, and so we either try to handle it over the phone or bring them in and really try to figure it out. But it's definitely a transition period that can be a little bit difficult to get through. Second question is, do you have any DBS patients with Duopa? I don't have any patients with Duopa. That's easy. Even though it came out in January, that's the pump system with the levodopa. Even though it came out in January, as of April or May, I think only 10 patients in the whole country had received it by then. Since then, I'm sure more have received it, and that number's probably going up quickly. But still nobody here has seized the opportunity. I've certainly talked to a lot of patients about it who I think it would help, but a lot of people don't necessarily want a feeding tube, in a pump to wear all the time. We have a team ready here in Baton Rouge. I have a gastroenterologist who's trained to do the procedure. He's very good. Dr. Ben Oob at GI Associates. The wonderful reps have, sort of trained us, and we'll do more training when the time comes. But as soon as somebody wants to do it, we're kind of ready to do it. The pump is fairly easy to program, and certainly easier to program than a deep brain stimulation, which we're used to doing. So we haven't had it done yet here, but that's only because nobody's really, jumped on it. I can understand people's concerns, though, because the same people who are candidates for Duopa are candidates for deep brain stimulation. So that's something where, it's all internal, and you don't have to have a pump or a feeding tube all the time. So, but there's no reason people can't have both. There's some studies in Europe showing that people have both DBS and Duopa, and when they got the second one of those, it helped them more than the first one alone. So there's no reason to believe that those two treatments are mutually exclusive, because they work in different ways.
We could always hope for a synergistic effect, 1 + 1 equaling 4 instead of 2. So that's possible. One question was, how do you know when it's time to consider deep brain stimulation? The same would apply, like Dr. Callaghan said, for Duodopa. Whenever the medicines just aren't working the way they used to, and you have more off time, whenever side effects from the medications, when you try to bring it up, are problematic. In other words, you could have too much dyskinesias, you could have too much orthostatic hypotension. In other words, whenever you stand up, you get dizzy, which you don't really want that. You don't want to pass out every time you stand up, so we try to avoid it. And whenever there's just a limit of the effectiveness that we could get with the medications. So that's whenever you consider other measures like Duodopa or deep brain stimulators. Anything else to that, Gerald?
Very good.
Okay, Dr.
So
Valancourt.
this is a two-part question. So the first part I'm going to do, and Tarina was going to do the second. So the first part says, how do researchers get most of their information? I would say there's several ways. First, we read. We read on the internet, so you can go to what is called pubmed.org, which is basically part of the National Institutes of Health, basically publishes every research article. And so it's a searchable database, and you just search. So you could look up alpha-synuclein and find a slew of articles that would be there, would be overwhelming. You could also Google this information. If you went to Google on your computer, you would also be able to find many of the articles as well, because Google picks them up. The other way we get information is we go to conferences and we talk to each other, and we criticize each other and we question each other, and we learn that way. So it's a very much a feedback process. We don't assume anything that we believe is right. We question everything, and that's basically what researchers do. They basically are trying to find things that are meaningful through question and feedback and going forward.
And so I'll take the second part of this question. Can we donate our brains for research? That is a great question, and actually it's a very, very important, taking the step of donating a brain for research is, clearly very personal. It's very important as well. There are brain banks. It's, the term that we use for the centers that will actually, where the pathologists and the clinical staff know how to take the brain when someone has chosen to donate it, and they have to handle it very, very carefully, because the time between when someone passes away and when the brain is preserved in a way that it can be used further for research, that time frame has to be very small, and the way that it's handled in that time period needs to be very particular, and so only certain places do that. One of the things that we're working on at the Michael J. Fox Foundation is trying to pull together a tool, a searchable tool, where people could, put in their zip code and then find the places within their area that are trained and do this kind of brain bank collection on a regular basis. I'm personally not aware of some in this area, but that's just because I'm up in New York. But it's conversations that you certainly need to have, obviously, with your family. It's almost like with any other tissue donation, like if you're donating your heart or anything else, that has to be communicated to the family. It has to be communicated to the medical areas that would be responsible for taking it. But it's a very important and key piece of the process, and some of the procedures do vary by state, which is part of the reason why it's hard for us to, no one can just recommend like a national protocol, for example. So just make sure you're aware of what those procedures are within your state.
On a similar vein to donating your brain, talking about end-of-life issues, there is a question of, is that something that should be discussed in the support groups? So that's something that everybody should have a plan, whether they have Parkinson's or not, because the end of life is coming for everyone. It's nobody gets out without that part of it. So I think it's important in today's modern world to have a plan for the end of life, both financial and to have a plan. ICU stays are very hard on not only the patient, but the family, and we had a booth out there today promoting a living will and what to do at the end of life. So how appropriate that is when talking with fellow Parkinson's patients is a very reasonable question. Whether it's addressed at the individual support groups, that's up to the group. I think having a good plan for the end of life is good, but not, some of the issues that end-stage Parkinson's disease sufferers face. It's good to know, what your plan is versus peg tube versus not peg tube versus what type of care you want individually. That's an individual decision. So it's something that should be taken seriously and thought of. But at the same time, I've had discussions with my family about, what to do at the end of life, their end of life, my end of life, because I think it's a good plan to have. So,
I just wanted to come back just real quick because I thought of something in this last little minute. In the question of donating your brain for research, something to think about when you have this conversation, if it's something you're interested in with your family. Also consider maybe if you're married, your spouse could also donate their brain as a healthy control. It's often very difficult to get age-matched and similar control brains because mostly the people who have the disease are the ones motivated to donate and share, but it's very difficult to get the healthy control brain. So just think of that. It might be a family decision.
There was a question about, I really didn't read it right the first time. I thought it was human engineering prescriptions or human something, but it referenced an insurance company and changing prescriptions. So insurance is great to have. You need it to function because medical costs are just very difficult to handle without it. I think insurance coverage, especially for people who are on quite a bit of medication, is an important question. The donut hole, it's not just a donut shop in Destin, right? It's something that nobody wants to face because it costs more money to get the prescriptions that you need. And the question was about a specific insurance company and are we having problems with it? And every insurance company is going to look for the most financially sound practices. Sometimes we agree with it, sometimes we don't. It's just trying to find the right balance. So that's, I think, the best way I could answer it. If anybody ever has any other way to talk about it, they're welcome to. All right. Any other questions down there that we didn't answer?
I have one left. Okay. So this question is asking for me to provide more detail on the current phase 1 trials for alpha-synuclein. So the ones that are furthest along, the ones that are down in phase 2, were the ones that I talked about that do the mopping up. We are funding, and other groups are also funding other trials in alpha-synuclein that are in phase 1. So just to reiterate what phase 1 means, phase 1 is really safety. So I think that maybe the question is also just asking what the earlier phases are and where the alpha-synuclein trials fit into that. There are trials that are looking at being able to reduce alpha-synuclein levels completely, so pretty much putting the brakes on the process that the cell uses to make it. Those are in phase 1, and there are some other ones in phase 1 to speed up the clearance, kind of like the garbage machine analogy. And I think that there's at least a dozen that are in the early stages. But again, the early stages of clinical trials are really testing safety. And those trials are actually done in healthy patients. They don't test safety in a patient who has Parkinson's disease. So once they get an idea of the safety profile and whether or not they can start changing, so you need to know it's safe at a certain level because you might need a higher dose to be effective in the disease, but at least you need to anchor that with safety. So there are a lot of other trials for alpha-synuclein that are in those early stages. I want to reiterate how the very shocking and disappointingly high failure rate for any drug that is in early stages. I'd say maybe 10% actually get through the full pipeline and get into the clinic where your doctor will prescribe it. But that's why we're pursuing many at the same time, hoping that all we need is 1 or 2. So if we can get to that step, that's the process.
One thing I want to mention too, as with previous years with this Parkinson's conference, we're videotaping all the presentations, and they will be available online in a matter of weeks, 6 to 8 weeks probably, and you can go and access them through the Pennington website and probably through the new NeuroMedical Center website, which will be out shortly. But you can access previous years' presentations as well. So please tell people who couldn't make it for whatever reason that they can enjoy the presentations online at a later date.
I would like to thank all the panelists for coming and lending their expertise to this event. Y'all did a great job. Thank you.